So today I'm going to present on toxicological emergencies in children. So I'm going to discuss some of the common poisons seen in children, and then what to do about it. I'm going to discuss pediatric poisonings, the pediatric context mainly. Poisoning in children is a preventable cause of morbidity and mortality, because most of the poisonings in children happen due to accidents, unlike in adults who mostly intentionally take the poison. Most toddlers or most children under 10 especially, they ingest the poison accidentally. So it is largely preventable by making the home environment poisonings. Oil is by far the most common seen in urban rural territories implicated in poisoning of children, especially the household plants. For example, oleander is grown as a decorative plant, ornamental plant, and there are lucky plants. They are also grown. People are not aware of the potential toxicity of these plants, and they are frequently grown in their home garden or sometimes inside their homes. And then children have the access, and then they ingest, and then they are more prone to toxicity with unsafe home environment. And because of this, ingestions are accidental, the dose is low, and then the mortality is quite low compared to adult poisonings. However, teenagers, the other group who tend to take the poisons deliberately because of their deliberate self-harm behaviors, it can result in mortality more than what you see in children. And also, the other contributor to morbidity and mortality is the harmful first aids practiced by the parents of these children. For example, giving a lot of water and various other, sometimes parents use soap water, coconut milk, various other solutions in an attempt to induce vomiting in these children. So that can result in sometimes aspiration, especially after ingestion of hydrocarbons. And this is not the first aid that gets aspirated, but this agent, for example, kerosene oil, can get aspirated and can result in aspiration pneumonia. And also, some of the medications, because the children have low body weight, lower volume of distribution, and because of that, the risk of having higher concentrations in plasma, some of the poisons, some of this, especially the pharmaceutical agents, can rise to very high levels within the toxicity range if they ingest sometimes even 1 tablet by young infants. So these agents like tricyclic antidepressants, beta blockers, they all can cause significant hypotension. Calcium channel antagonist, opioids can result in coma, antiarrhythmics, theophylline. So they all can, after ingestion of 1 or 2 tablets, can result in significant toxicity. And also oleander and organophosphate also can be quite detrimental. So if you look at the general approach, it's the same compared to an adult. So we have to, so resuscitation is the priority in any of a child who is presenting with a serious poisoning event. So resuscitation is attending to your airway, breathing, circulation. And then once you have stabilized your airway, breathing, circulation, you have to do a quick risk assessment. I hope you know now by now how to perform a risk assessment. And then, those with not so high risk, then they can be treated with relevant supportive care, and then investigations can be planned. And then if they have presented within the correct time frame and the patient is stabilized hemodynamically and respiratory wise, then decontamination can be administered, provided the airways protected. And also elimination, antidotes, and then disposition as to what to do after the patient is stabilized within the emergency department comes next. So some of the poisons, for example, opioids, benzodiazepines, so attending to airway is a priority. And also ingestion of corrosives, alkalis can damage the airway. So in such children, protection of airway is a priority. And some of the other agents like cholinergic organophosphates, and where there is a high risk of aspiration pneumonia, CNS depressants also can either depress the breathing or sometimes result in respiratory distress. So in both of these occasions, attending to breathing is important. And then circulation, most of these cardiac drugs can result in circulatory impairment. So attending to blood pressure, maintaining the blood pressure and the heart rate within the desired range is important. And then some of the toxins can cause seizures, like especially the anticholinergic agents. And then some of the agents can cause hypoglycemia. For example, agents like anti-diabetic drugs, salicylates, and then correcting hypothermia in syndromic presentations like serotonin toxicity, anticholinergic, sympathomimetic toxidromes. So attending to hypothermia is a priority because they can cause malignant hyperthermia. And then some of the antidotes can be administered in the resuscitation stage. For example, naloxone after, for example, pethidine overdose when a newborn is, newborn presents with respiratory distress. Then we administer naloxone them and there. We don't follow, during the stabilization phase, we administer naloxone sometimes. So antidotes may have a place in the resuscitation phase as well. So risk assessment is very important in pediatric poisonings because children are different from one child to the other. Because if in adults, the standard weight is 50 kilos, even if they are obese. However, children, as they grow old, their weight, as well as the body surface area, as well as the volume of distribution, all change. Therefore, we have our risk assessment must be individualized. Yeah, and then heart rate can be variable in some ingestions. For example, tachycardia can be caused by sympathomimetics and anticholinergic agents, whereas bradycardia can be caused by most of the cardiac drugs as well as cholinergic agents. And then blood pressure, it can be either low or high blood pressure, and temperature can be hypothermic if you present with alcohol ingestion or certain anticonvulsant ingestions, or there can be hyperthermia if the patient present following ingestion of an anticholinergic agent or a sympathomimetic agent. And the conscious level, the D, is also important to be assessed. So conscious level can be low in the presence of ingestion of opioid sedatives, antihistamines, and some oral hypoglycemic agents. And pupil size is very important. Again, pinpoint pupils are characteristic of opioid ingestion, and sometimes when they present with a cholinergic crisis, whereas dilated pupils can be seen with ingestion of anticholinergic agents and sympathomimetic agents. So decontamination, we use decontamination, but the place of gastric lavage is limited in many poisonings. So we have to be very clear about whether to give it or not. For example, if the patient presents with an agent that is not absorbed to activated charcoal, like lithium and iron, then there's a clear place of giving gastric lavage or even giving a bubble washout. However, if the patient presents late after 2 hours, so we have to review, and then sometimes we have to get that information from a poison information center to decide whether it's actually worthwhile giving gastric lavage. Activated charcoal is still recommended for many toxic agents. However, the time window is very important because most of the agents become, most of the poisonings, the activated charcoal become less effective if they present late, especially after 2 to 4 hours after ingestion. But some agents in overdose, they will delay the gastric decontamination. For example, ingestion of agents like theophylline salicylate. So in such incidents, in such cases, there is place for administering even multiple dose activated charcoal. The weight the dose depends on the weight of the child. The standard dose is 1 gram per kilo. So if the child's weight is 20 kilos, the dose of activated charcoal is 20 grams. And children generally refuse, especially younger children, refuse activated charcoal because of its unfavorable taste. It's recommended that you mix it with some flavoring agent like yogurt or ice cream, so that will increase its palatability and the compliance. However, giving activated charcoal, before that, we have to ensure that the child's airway is protected, especially in children who present in a drowsy state. And so, as I told, multiple dose activated charcoal is indicated for certain agents like salicylate, theophylline, and barbiturates. However, it's not effective in lithium, iron, and alcohol poisonings. And charcoal is contraindicated in certain instances where there is a risk for bowel obstruction, bowel hemorrhages. So that can be seen with iron ingestion during the acute stage. And also liquid hydrocarbon ingestions because of the risk of aspiration of these agents. So acids and alkali. So understand there are clear contraindications also for administering activated charcoal. Emergency management and disposition. Most of the time, like I told before, the ingestion is accidental and dose is trivial in most occasions. So such children can be managed with a period of observation. So you take, a nursing officer can take a series of observations. Sometimes it can be done in emergency departments. So like I told, it's very important to do a risk assessment. So in the same way that children, the risk assessment depends on the age of the child, size of the child, your antidotes as well as the treatment doses. All depends on the weight of the child. Most of these injections are trivial, so they can be managed sometimes even without needing the child to be admitted to the ward. For example, in most of the poison in emergency department settings in the UK and Australia, most of the children with trivial ingestions, they are discharged from the emergency department itself. So that will save a lot of money to the government, as well as we do manage these children in a more structured, cost-effective way. Otherwise, if you start transferring all of these children from the rural hospital to the nearby hospital, so that involve a lot of finances to arrange an ambulance, arrange a medical officer, arrange a nursing officer, and a minor staff. So in this way, it's very important practically to do a proper risk assessment. And most of these children with trivial ingestions can be discharged from the emergency department itself in most occasions. However, if the child becomes symptomatic, for example, if the child develops vomiting or if the child develops drowsiness, it's an appropriate thing for them to be admitted to the ward and then be observed up to a period of 24 hours to make sure that they are out of danger and their observations remain stable, and also they are back to normal after that period of observation. And most of these children who become symptomatic, it's recommended that we do some limited investigations appropriately. So if the child presents with ingestion of anti-diabetic drug, maybe a tablet of glibenclamide, so it's good to do a blood sugar. Or if the patient presents with vomiting with unknown ingestions, it's good to do an ECG, and sometimes if facilities are there, to do a blood gas as well. Right, so we'll talk about some of the specific poisons now. So paracetamol, so like I told, is it's the most common pharmaceutical agent ingested by children as well as in adults. And what I'm showing here is the 2021 Australia-New Zealand guidelines, one of the recent most guidelines that we have for management of children with paracetamol. And also we have our local guidelines as well as that were published by the College of Internal Medicine. So what this guideline says is, like, if the child presents with a single lower dose of 200 milligram per kilo, it's recommended that this child will need not only admission but also treatment. Now the problem we have is we don't have paracetamol levels. Even in most private settings as well, we don't have a paracetamol level, and it's quite expensive. It costs about 10,000 rupees. And for these reasons, we have to rely on the ingested dose in assessing the risk for liver toxicity. And because of that limitation, in most of our centers, we take the dose as 150 milligram per kilo, not as 200 milligram per kilo. So if the child presents with a single lower dose of 150 milligram per kilo, and that child warrants admission, and then if you are sure about the dose, after doing the baseline investigations, including the ALT, AST, and an INR, it's recommended that the child is started on N-acetylcysteine. And sometimes parents anxiously give an overdose multiple times. It's not a single overdose, but multiple times, which we call a supratherapeutic ingestion. So if this dose is above 150 milligram per kilo and administered over a period of less than 48 hours, or more than 100 milligram per kilo administered over a period of more than 48 hours, again we consider this as a dose that has potential toxicity for causing liver damage. So such children warrant initial investigations and activated charcoal, and followed by treatment. And we can assess to do the paracetamol level and then plot it in the remarkable nomogram. So let's move on to the next toxin, salicylate. I hope you had the session on the module on the lesson on salicylate as well by now. So salicylate in children, they come after ingestion of local preparations, methyl salicylate, various balms that are used at home as kind of household agents that are used for pain relief by adults. So they are put here and there, like they are kept here and there, and then children accidentally lick them, sometimes ingest them. And also this methyl salicylate is more toxic than tablets, so that can cause serious toxicity. Salicylate resulting in delayed absorption. Therefore, in overdose, significant ingestions as well as ingestion of sustained preparations. And we don't have this mainly, So practically, what we do is we do a series of blood gases, and then be guided by the acid levels or the pH and the bicarbonate levels to guide our treatment. But if you have facilities for salicylate measurements, so that is considered very useful to manage the patient. And it can cause, the main mode of treatment is we use urine alkalization. So in the presence of urine alkalization, the salicylic acid gets excreted through the kidneys, and then thereby you can enhance elimination of salicylate and then reduce toxicity. So the main mode of treatment in the presence of non-life-threatening toxicity is urine alkalization. So we use a bicarbonate infusion and then monitor the urine pH to keep it more than 7.5 and to have a urine output of more than 3 ml per kilo per hour. And then do a series of blood gases and then monitor for improvement of any metabolic acidosis if present. But in the presence of a serious toxicity, then urine alkalization may not be enough alone, like it's not a standalone treatment, and then we have to consider hemodialysis as well. And other thing is it can cause CNS hypoglycorrhea. So hypoglycorrhea in the presence of a normal blood sugar. So that can significantly damage the brain. So even if your blood sugar is normal, in the presence of a serious ingestion, it's recommended that you give glucose, an infusion containing glucose. And then yellow oleander, it's seen in both urban as well as rural areas, but serious presentations are very infrequent in children. But if you go to Polonnaruwa and Radhapura, you can still find children presenting with ingestion of yellow oleander. And in adults, as you all know, it's a very common kind of agent used, especially in the eastern and the northern and the north central areas of the country. So it's seen as a very common poison used by the adults. But the problem with oleander is, it's because it's a plant product, and then it can have variable toxicity thresholds, as well as the dose can be highly variable, and in some instances there can be delayed toxicity. depends on the part of the nut that you have ingested. As well as we don't have the expensive treatments most of the time in many hospitals, as well as we don't have the digoxin levels. So all of this will complicate treatment in our setting compared to more developed settings. The main action of yellow oleander is that they inhibit the sodium potassium ATPase channels in the heart, result in bradyarrhythmias and heart blocks, and also hyperkalemia. And the affected children can present with hyperkalemia, cardiotoxicity, especially bradyarrhythmias and drowsiness. And in serious cases, so it can result in ventricular dysrhythmias and asystolic arrest and subsequent death. So these children, if they present, they have to be monitored for at least 72 hours because of their variable toxicities. There can be sometimes delayed toxicity, although initially the child looks stable, especially in the presence of a serious ingestion. So if you can do a risk assessment properly, and if you find the child has ingested a significant amount, even if the child is asymptomatic, it's important that the child is kept in the ward for a prolonged period rather than discharging early. And we had to monitor the electrolyte levels. Hyperkalemia is the common presentation, but sometimes hypokalemia can be seen. That indicates a poor prognosis. And we don't have facilities for doing digoxin levels. And because of the delayed absorption, multiple dose activated charcoal has a place. And then hyperkalemia can be treated with standard treatment, but we have to keep in mind that we should avoid calcium because in these children, in these patients, because of the blockage of the sodium potassium ATPase, there's high amounts of intracellular calcium. So if you give more calcium, that can lead to a stone heart, resulting in serious ventricular dysrhythmias. And to control the bradyarrhythmias as a bridging treatment, you can use atropine, but some of these patients will need cardiac pacing and antidigoxin fag as well. And kerosene oil and various, this type of, liquid hydrocarbons are seen mostly in children, not in adults. So it's one of the most common household poisoning agent seen in children in Sri Lanka. And morbidity and mortality mainly are related to pulmonary aspiration. They can cause various other system toxicities like kidney toxicity, CNS toxicity. However, they are quite rare. And most of the damage or the risk is there because of the risk of liquid hydrocarbon aspiration resulting in a chemical pneumonitis. And in all of these liquid hydrocarbon ingestions, activated charcoal is contraindicated, gastric lavage is contraindicated, and most of the time these children will need a period of observation. And in here, there is no indicate, the decontamination agents are ineffective, and the treatment is either ethanol or fomepizole. And in serious toxicities, hemodialysis can be indicated. And iron is another important agent to know when it comes to pediatric poisonings, because iron, comes with the oral contraception pack. And most of the children who are born with low birth weight, they are kept on various vitamin formulations as well as iron formulations. And parents tend to underestimate the risk of iron because most of these children in the MOH clinic, in public health center, again iron is used very frequently. So they think it as a kind of a very useful agent, and they tend to underestimate the risk. However, as you know, it's one of the very seriously toxic agent. And if you ingest a dose of more than 150 milligram per kilo, it can be fatal. The standard pediatric dose used in treatment is 6 milligram per kilo. But if you ingest a dose more than 20 milligram per kilo, which is 3 times the dose of the standard dose, it can result in potential toxicity, and such children will need careful observation. During the acute stage, iron toxicity can cause mainly the GI problems as well as the liver damage, so that can result in GI hemorrhages, as well as convulsions and sometimes circulatory collapse and serious liver toxicity. And as you all know, iron is not absorbed in charcoal. We have to give whole bowel irrigation as the decontamination and the elimination technique. And the antidote is IV desferoxamine, which can be given up to a total kind of, which can be increased up to 15 milligram per kg per hour infusion for those present with significant complications like shock, coma, or fits. And measuring iron is also important. But in most of the emergency departments, we don't have the facility to do it at as an emergency test. And here what we can see is a patient with a serious iron poisoning, and you can see multiple iron tablets deposited within the stomach. And tricyclic antidepressants mainly an issue in teenagers. Antidepressant and the psychological problems are quite common in teenagers, and most of these teenagers are kept on one of the tricyclic antidepressants. Who have a more, who have higher risk of undertaking an act of deliberate self-harm. So they tend to drink their own tablets. So tricyclic antidepressants has multiple actions. It has anticholinergic effects. It has direct cardiac effects causing cardiac dysrhythmias, as well as it blocks fast sodium channels in the heart and the brain, resulting in various presentations: cardiac toxicity, CNS presentations, hypotension, bradyarrhythmias, resulting in significant toxicity. So if they present with that has the potential to cause death because of the direct cardiac toxicity. So what it does is they go and bind the cardiac channels, the tricyclic antidepressants. So what we do is by giving the sodium bicarbonate, we try to alkalinize the plasma. And then this excess sodium goes and try to dislodge the tricyclic antidepressants from the cardiac receptors, trying to reduce the risk of serious toxicity. And here again, we have to monitor the blood gases, maintain the pH at a desirable range to keep the plasma alkalinized, and then carefully monitor the patient's hemodynamics. And then the patient might need other supportive treatment, especially if they present with a serious toxicity, including inotropes to maintain the blood pressure, as well as heart rate within the normal range. And there can be less straightforward presentations in children, especially in the younger children. For example, child presenting with unconscious, like loss of consciousness without a clear etiology. They might present with cardiac dysrhythmias with no clear etiology. So in such presentations, we always have to suspect an overdose of recreational drugs as well as various toxidromic presentations. But in doing so, there can be medical emergencies as well. For example, a teenager might present with septicemia, meningitis, meningoencephalitis, present with a seizure. And then, if in the absence of a clear history of ingestion of a substance, we have to consider these medical causes as appropriate, as well as sometimes by using a toxidromic approach, we can, for example, if a teenage is found on a street presenting with respiratory depression, and it is so remember that in about 10-15 years, we might see more and more teenagers with substance abuse because it has become a significant problem in other countries as well. And there are various novel substances of abuse, that come through, and across different countries, and will be a major burden in future. So it's very important that we are aware about this unusual presentations. And on the other hand, if the in the presence of a sedative toxidrome, the patient can present with a CNS depression, respiratory depression, and the pupil size can be variable. Sometimes it can be dilated, sometimes it can be a constricted pupil, and the blood pressure and the heart rate can also be variable in the presence of ingestion of agents such as diazepam and other sedatives. So in the presence of a diazepam or a benzodiazepine overdose, we don't generally use flumazenil because of the risk of causing convulsions. Supportive care is the main mode of treatment. And then 3 other important syndromes: cholinergic toxidrome that occur following ingestion of organophosphates and carbamates. So they result in widespread cholinergic activity, diaphoresis, lacrimation, urination, diarrhea, bronchuria, vomiting, pinpoint pupils, salivation. And during the neuromuscular blockade in the intermediate syndrome, it can also result in neuromuscular paralysis. And then, the treatment in the presence of cholinergic toxidrome due to organophosphate mainly involves decontamination. Here, the decontamination is mainly the local decontamination, and then atropine, airway management, and then palindroxin. And sympathomimetic and anticholinergic toxidromes are kind of somewhat similar syndromes. What I put in red here are the distinguishing features between the two. Sympathomimetic toxidrome can occur due to ingestion of recreational drugs like MDMA, commonly known as ice, amphetamines and MDMA, and cocaine also. So they present with increased sympathomimetic activity, resulting in tachycardia, hypertension, hypothermia, agitation, delirium, tremors, dilated pupils, convulsions. So they can result in myocardial infarctions because of the increased metabolic demand to the heart. And in the presence of a sympathomimetic toxidrome, so management is mainly supportive. So you try to settle down the patient using sedatives, active cooling, and here it's a hyperthermia. It's not a fever, so paracetamol is not actually effective. So you had to use active cooling measures to treat sympathomimetic toxidrome. So anticholinergic, again, similar presentations, but their bowel sounds are less and they have a dry skin as compared to sympathomimetic toxidrome, where you have increased bowel sounds and increased sweating. And the agents are also different. It can be a plant poison like athana or datura ingestion, antihistamines ingestions, atropine poisoning. And the management is mainly supportive care, benzodiazepines, and active cooling. And the other important thing is poisoning and deliberate self-harm. It's seen mainly in teenagers. So not only that we medically manage the patient, and after that, once the patient is stabilized, it's very important that these children get assessed by a child psychiatrist to assess the future risk of deliberate self-harm, as well as to support the patient and their families. So the key messages I want to highlight that in most childhood ingestions, they are of low risk, trivial. So consider observing them briefly in emergency department, and then repeat your risk assessment. And then if you determine the child is at very low risk and the ingested agent is not a serious risk to the child's health, then you can consider discharging the child. But also be aware of certain agents. For example, oleander, for example, rat poisons, they can cause delayed toxicity. So such children, will have to have a proper risk assessment, and then even if they are asymptomatic, we need to have admitted in the hospital, and then after discharge them after they are clearly out of risk. So all in all, the risk assessment is a very crucial step in the management of acutely poisoned child. And in adolescents, identification of toxidromes is very important to formulate a correct differential diagnosis, rule out the medical courses appropriately, and then manage these less straightforward presentations.